As we speak, ST elevation myocardial infarction, or STEMI as we call it, or heart attack as we know in common language, is killing more people globally and in our part of the region than any other disease. WHO statistics are that as we are speaking and going forward in 2020 and 2025, overall mortality from cardiovascular diseases, specifically myocardial infarction, would contribute to around 25% of all global mortality. So 1 out of 4 people across the world will die of diseases related to coronary artery disease, and specifically myocardial infarction is the most common killer here. So globally speaking, the standard of care in the developed world is opening up of coronary arteries during myocardial infarction by primary angioplasty.
Okay, if we start from the beginning, the Tamil Nadu STEMI program was a program that was sponsored by the Indian Council of Medical Research, and we partnered with Tamil Nadu government in this particular program. What we did was what we call a very unique model of heart attack management. It's now known as the STEMI India model, which really is a hub and spoke model. A hub hospital with a cath lab is connected to multiple peripheral centers. Now, some of these centers could be as much as 100, 120 kilometers away from the hub hospital.
See, ST segment elevation MI is the same all over the world. The management, the ideal management today is to reperfuse the affected artery as soon as possible, within the first hour if it is possible. While this is possible in the West because patients are situated at short distances from specialty hospitals, this is not a possibility in India. People are situated in far-flung areas, it's a big country. Getting to a specialty hospital is a problem. There are traffic snarls, and there are so many delays in the patient getting from his place to the hospital.
Well, awareness of heart attack for the patient is by virtue of awareness of the treating physicians. Therefore, it is very important that the first medical contact when a patient comes to any doctor, whether he's an MPS, MD or a cardiologist, he must know what are the symptoms, and he should magnify and understand that the given symptom is of ischemic heart disease. I would like to highlight 3 important points.
STEMI is an acute emergency, as you know that most of the patients who are coming to your chamber, see 60 or 70% of the physicians are doing a chamber practice. Chamber practice means where you have only a chamber, you're sitting there and doing a consultation. Now there are 3 important things while a patient is landing into a clinic. First, there are chamber doctors who are doing only chamber practice. Secondly, there are institutional practice where you don't have a direct cardiac, it's a non-cardiac institutional practice. And third, where you have a cardiac lab.
The physician play a very important role in management of STEMI. Like if patient comes to you, because most of the patient, they reach to their physician first. If they don't have a nearby cardiologist or cardiology facility hospital, so the role of physician is first to identify and recognize as soon as possible it is STEMI or acute coronary syndrome. And if it is acute coronary syndrome, by doing an ECG and getting enzymes done, and when he is confirmed whether ECG is showing changes of.
So there's 2 main important parts of that question. The first is we want our patients who are having chest pain or shortness of breath, especially if they have risk factors like diabetes or smoking, to come to a hospital as soon as possible so that they can get an EKG. From the medical standpoint also, the EKG is diagnostic of STEMI, and so if you get that EKG within the first few minutes, when the patient shows up, you can diagnose it and you don't need any other tests. You don't need cardiac enzymes or anything else. The EKG will usually tell you the answer if the patient has a STEMI, and you can then work on trying to get.
When it comes to the management of life-threatening ventricular tachyarrhythmia, in the setting of ST elevation MI, the cornerstone of the therapy remains well executed STEMI care, and that is what we are all hearing about. How do we manage STEMI patients in this particular conclave? When it comes to the prevention or the treatment of ventricular tachyarrhythmia in STEMI patients, a few things to be done.
Understand that angioplasty is an opportunity where we actually can greatly counsel the patient for lifestyle modifications. If you ask a healthy patient that go for exercise, go for diet, he will never do. But after an attack, patient, his relatives, everybody is concerned. They realize that something big has happened and this should not happen in future. So as a physician, you should be emphasizing on two different factors: pharmacological, non-pharmacological, drugs and non-drugs. So drugs, there are 4 or 5 important drugs which a physician needs to ensure that his patient continue for at least 1 year. The most important being antiplatelet drugs. They are the cornerstone for preventing.
Transradial intervention, actually they are done from the radial artery, while the conventional transfemoral interventions are done through the femoral artery. Femoral artery means through the groin. So if you are doing it through the groin, there are lots of problems to the patient. Patient has to lie down for a long time after the procedure, and there are chances of bleeding complication, hematoma formation, pseudoaneurysm formation, excess site other complications, and AV fistula formations. So there are too many complications of
cardiac arrest.
Yeah, so cardiac arrest is a big issue as well. Many STEMIs, the presentation might end up being cardiac arrest as the initial condition. Now, not all cardiac arrests are due to STEMI or even coronary artery disease. They can be due to other things, cardiomyopathies, genetic abnormalities such as channelopathies. But regardless of the etiology, the cath lab has a critical role in cardiac arrest management, because these are sick patients and there's very few places that are better for a sick patient to be in the first few hours of their arrival to the hospital than in the cath lab.
But though this is a guideline recommendation, in the practical scenario it is not possible even in many parts of the Western world due to a lot of logistical reason. When you consider our country, there are a lot of problems because it is not a country which is like Europe. It is not a country like America. Our country, different states have different problems. For example, if you take the state of Uttar Pradesh, my friend was telling today that a patient who is developing a myocardial infarction in Moradabad, and you cannot transport him to Delhi for an angioplasty. It is impossible. So, a lot of problems, especially one, transportation.
Clinicians who are actually settled in periphery, those who do not have, they have a small nursing home without an ICU facility, I would suggest them that they at least keep one ECG machine so that they can diagnose the STEMI patients at the earliest. A patient who comes to you with a pain, you can simply diagnose them as an ST elevation ACS or no ST elevation, and then you can do some tests with like troponin T, whether to categorize whether it is an ACS or not.
Second topic which I'd like to talk about is why do we hold such congresses? We hold these congresses not only to educate but also to interact with faculty from all over the world who have been pioneers in this area and learn the best practices from all of them. The third thing we like to do in these conferences is to get the administrators and the governments to come to this meeting so that we can talk, because without the government you cannot create a system of care. Nowhere in the world does a system of care run privately. So it is very important that the government realizes that this is important and creates the infrastructure to help in creating a system of care. The third thing which we found very quickly is that primary angioplasty, which is angioplasty during an acute heart attack, which is a norm in most of the westernized societies, is not possible in this country because cath labs are in metro cities.
Well, the dawn of 21st century has given us a quite lot of newer molecules which has helped us in sort of treating STEMI patients to a greater extent pretty well. And one of conventionally we have been using the dual antiplatelet drugs which involve the aspirin and clopidogrel. Aspirin, we have plenty of data right from for centuries, more than 100 years, we've been using aspirin, and the antiplatelet dose of aspirin is anything between 75 to 325 milligram. Generally, we use 75 to 150 milligram. We have also some data which has come recently, which show that if one uses an intravenous preparation of aspirin in the dose of 250 to 500 milligram, it may be better than the conventional oral dose of aspirin. But then oral, make it a point to use a chewable aspirin. That is the most important part of aspirin. Now come to the second drug. We have been using clopidogrel for all these years, maybe about 3 or 4 years prior.
And it's very clear in the literature that thrombolytic therapy saves about 40 patients per 1000 patients if you give thrombolysis therapy. It's a very useful therapy in a patient of STEMI. Unfortunately, the fear in periphery and small hospital is too much regarding giving the thrombolysis. And I always request everybody that don't fear to give thrombolysis. It saves lives more than the small risk of bleeding. The confusion of thrombolysis is that it's a costly thing. No, the streptokinase, which is the first thrombolytic therapy, is costing not more than 1,000 rupees in the periphery.
So, the registries are actually very important. So as we're in the process of setting up STEMI networks and STEMI processes of care in India, I think it has to go hand in hand with having registries where you can collect the information. And so unless you're actually able to measure and monitor what you're doing, you can never make changes and never realize what things are working and what things are not. So I think it is very, very critical that they have to go hand in hand with all the usual endeavors to see how we're doing for process metrics such as door to balloon times, etc. Are we actually able to affect patients' outcomes by doing by offering pharmacoinvasive or primary PCI? What are the cost issues? So the registry, and it's not just.
Sir, and what is the role of temporary mechanical support in cardiogenic shock?
Now, temporary mechanical support has revolutionized the care of patients with cardiogenic shock. These temporary mechanical devices allow us to stable the hemodynamics of the patient and preserve end organ function. So when patients come to us with shock, let's say with a large myocardial infarction, and they remain hemodynamically unstable despite revascularization, putting them on these temporary devices gives us the time to allow the ventricle to recover, as well as to make decisions that we call bridge decisions.
So, as I mentioned, this is a very catastrophic condition. So, patients who have acute myocardial infarction and develop this complication, they deteriorate very fast hemodynamically. So, any patient who deteriorates between 2 to 4 days, one should always suspect ventricular septal defect, or what we call as ventricular septal rupture, and it needs to be diagnosed well in time. And obviously the best way to diagnose would be the echocardiography. A 2D echocardiography very clearly can show that the patient has a ventricular septal rupture, which can be the anterior ventricular septal defect rupture, which is when the patient gets an anterior myocardial infarction, or it can be the posterior or the inferior ventricular septal rupture, and the patient gets a posterior infarction.